All right. Well, welcome back, Carol. We are super glad to have you here. To all of you watching, we really enjoyed, and we know that all of you did as well, the webinar with Carol last week. And there were so many wonderful questions that came in the Q&A. A lot of them came in anonymously, which made it hard to respond to. However, that in conversation, that's now given us the opportunity to have another follow-up chat with Carol. And this is going to be a little more informal and kind of go through some of those questions to give everyone an opportunity to hear your answer. So thanks for joining us again today, Carol.
Thank you so much for figuring this out. This is the way to do it. At the end of every webinar, I say, here's my email address, here's my phone number. Call me if you have questions. And that's not really practical, probably. This is great. So thank you. Very, very smart.
Absolutely. Well, I think maybe it's best if we just dive in and go through some of these questions. Okay. Um, well, I guess to start, we wanted to clarify a position. And Dave, I don't know if you want to give a little bit of follow-up on that.
Sure. So we were talking about, Carol, you and I were talking about dispositions and the nurse needing to use their clinical judgment to change the disposition. And there was some conversation about upgrading the disposition, downgrading the disposition. And as we all know, most organizations support letting nurses upgrade the disposition, but many organizations don't support downgrading the disposition. And you had some comments there about the legality and the legal defensibility of that. And some people were a little confused by that. So I'm just going to toss it back over to you to clarify what you meant by that.
Thank you very much. And I've reflected on this. This is part of the difficulty as an educator. I'm used to looking at faces, and when people look puzzled or if they didn't understand what I said, those hands go up, and that's very helpful. And of course, in a webinar setting, we can't. Um, I remember what you're talking about, and I understand why there would be some confusion around that, because I think I probably had a subcontext that was the big message that I really wanted to send, and it got lost in the verbiage. So let's just do this. If you have an, an organizational policy that allows you to upgrade and or downgrade, first of all, you need to comply with that policy. If you disagree with the policy, it is your responsibility as a professional to work with your leadership and your team to try to fix it the way that you think is going to be in the best interest of your patients. Um, and I think, like Dave said, the question of upgrading is probably moot at this point. I don't know of any organizations that would not allow a nurse to, using his or her own discretion based on their judgment, upgrade. The question that came up was about downgrading. And I looked back, listened back to what I said, and I said, if you use the protocols and you have a bad outcome, it doesn't matter whether you downgraded or not. You're going to be in trouble in court. Is that basically,
You said that
if you have a bad
if you
outcome?
don't use your clinical judgment, that you're going to be in trouble in court.
Okay, so thank you. So here's one thing, a disclaimer I need to throw out there first of all, and I do this routinely. I'm not an attorney, and I'm not providing legal advice to anybody. What I'm speaking from is my own experience as an expert witness. And it's not my intention in bringing these issues up to help you figure out how to stay out of trouble in court or not get sued. My point in bringing these up is to emphasize the absolute importance of using judgment, um, when we are using protocols, period. That protocols are guides for us, decision support tools are guides for us, but we need to have our head fully engaged throughout that process. So, what I probably should have said, and this would have been less probably ambiguous, is if you are doing a telephone triage and you have a bad outcome, your actions, your judgments, your results are going to be scrutinized. And there are several things that will be looked at. One will be, how did this nurse apply the protocols? The second would be, did this nurse individualize this care appropriately for the patient? Um, and deviate from the protocol as indicated based on specific nursing judgment that would, I guess, supersede a protocol in the void. But no, what you have to do when you get on the phone is simply use your best judgment. Use all of the tools available to you. Follow all of your organizational policies. Some organizations have policies that require nurses to check with a provider before they downgrade. I think it's great to, if you're downgrading, to check with somebody else. Two heads can be better than one. So even if you don't have a provider available to you, check with a nursing colleague. Just sort of bounce it off of somebody else to be sure that they believe that your judgment is sound and they also believe that you will not experience bad outcome.
I
So
think that, I mean, I think that you really do capture there. And I think part of that captures the worry that many organizations have. I've actually talked with this about with the nurses and the physicians at Schmidt Thompson, because their user's guide talks about everyone should have the ability to upgrade. They specifically don't talk about downgrading. And it's a safety thing for many organizations, because if you think about it, if the protocol is saying you need to go to the ED, and you bring them into the office, if they really needed to go to the ED, if there was some reason they needed to go there, that could be a problem, and could wind up, as you're talking about, in the bad outcome. So that's where I think if you are downgrading, there are times where downgrading is going to provide better care. You gave a great example of continuity of care of someone coming into the office if they could get in very quickly, and that continuity of care might give better care to the person. But the reality is, sending them to the ED, as the protocol says, isn't going to harm them. They're going to get there and they're going to have all the resources of the ED, but you might provide better care and better patient service. But that's why organizations that do allow downgrade sometimes have a policy, such as you suggested, to have someone else involved in that decision, just as that safety piece in there. If you have that opportunity with your organization, you can potentially provide better care to your patients. And if you're checking with someone, two of you agree, you are providing safe care. Last thing I want to throw in here, I don't remember and I apologize, but the name of the person we interviewed, but on our blog article, um, the um, in our blog article, there's legal considerations in nurse telephone triage, and we did interview a legal nurse expert about the criteria used in deciding whether someone's at risk. Great information in there, and it really talks about that piece that you always talk about, Carol, that combination of nursing judgment and protocols and what is the standard of care. So that's a nice other piece to be in there. But I'm going to echo what you said. Follow your organization's policy, use your nursing judgment, and in the end, take care of the patient. So I think that
thank
covers
you.
what we wanted
Yep,
to say about that.
100%.
And
But
there was, go ahead. Sorry,
sorry, I
Carol.
was just going to add one last thought, just
Yeah.
for, I think, to help solidify this for everybody. You are going to be held accountable for the standard professional nursing care. which I think we can always say goes back to use of the nursing process and using clinical judgment. So that's really how you would be evaluated. If you were to have a bad outcome, it would be based on whether or not you complied with the standards of professional nursing practice. So as long as you're thinking about what you're doing and using the tools available to you and consulting when it's indicated, you're going to be fine.
And I will say that standard of nursing care, because this I do remember from talking with the legal nurse lady, is is the standard. You do not have to be the best nurse ever on every call. You have to meet the standards of care. So don't scare yourself thinking, oh my gosh, I have to be absolutely perfect on this. You want to be, we all do to take care of patients, but the standard you held to is that standard of nursing care.
Correct.
But I think we have a whole
Well
bunch of
stated.
questions you said, Krista, so I'll
We
toss it
do.
back to you to move us on.
We do. And that conversation sort of leads us into a question that came in the Q&A. Someone asked, are there resources, and this is kind of a general question, but are there resources and or evidence out there that supports this, in parentheses, using nursing judgment and critical thinking?
And I have pondered that question over and over, you guys, because I simply don't know how to answer that, probably to satisfy the person who asked it. Yes, there's all kinds of evidence. It's called nursing quality assurance. Um, we know as professional nurses that we have to use clinical judgment. I can't even imagine how a study would be designed if that's what you're looking for is, a comparative study looking at the nurse followed the protocol here but didn't use judgment, or the nurse used judgment but didn't follow the protocol, or the nurse did both. I I can't even imagine asking a nurse to do telephone triage without using judgment. So that study's never going to be done. But yes, there is plenty of evidence that as professional nurses, and hey, you guys, that's why RNs are on the phone, is because that's what we know how to do. We understand critical thinking. We understand individualization of care. So I hope that answers your question.
I can
Um,
toss something in on that because it's something that actually bothered me, a study that came out a few months ago from a company making a symptom checker. Because a symptom checker that a patient goes through is arguably going through a protocol with no nursing judgment. And they had their study compared their symptom checker against the protocols that the nurses use, the Schmidt-Thompson protocols. And it said, look, in these, and they had maybe 50 different scenarios, we were almost as good as the Schmidt-Thompson protocols. But the piece that bothered the heck out of me in that study is they had someone using the Schmidt-Thompson protocols with no nursing judgment. They just blindly followed them and they came out and they said, oh, look, blindly following our symptom checker and blindly following the protocols, they get to a similar outcome. And like, you're missing the point. And this gets back to the conversation we had about what can't you replace with AI at this point in time? The nurse in there, because the Schmidt-Thompson protocols are not meant to be used alone. They're meant to be used in combination with a nurse. And that study to me shows that yes, there is value in that nursing judgment. There is critical part of that, and that's what gives you the optimal outcomes, which is why we're not turning all this over into chatbots using symptom checkers. So there's my thought on that study.
that's fascinating, and that's one thing that I think is really important. I've makes me think about the people that I've spoken with, either in consultation, in an educational setting, or just in conversation, who've said, "Well, we've never been sued, or we've never had a bad outcome." And my retort to that is, number one, you probably don't know whether you've had bad outcomes or not, because you all don't always get to hear about those. But secondly, if you haven't had any bad outcomes, Great. You have been super lucky. That doesn't mean, or you're using the process perfectly and you've been lucky. But that doesn't mean that you shouldn't still use all reasonable prudence, which is having registered nurses practice nursing.
Okay, so that actually answers one of our questions. Because one of our questions that came in the Q&A, Carol, what are your thoughts on the scope of practice of LVNs, specifically, but of course LPNs, and as it relates to the assessment aspect of this?
Yeah,
So,
and that is such a great question. And one person actually did provide her email address. And so I've already corresponded with her directly about that. And I believe that we are going to set up a conference call with her leadership to try to help clarify this. But I think one of the biggest issues that we're facing, and in looking at revision of the AAACN telehealth standards, one thing that continues to trouble me is that there doesn't seem to be a good understanding of what telephone triage or telehealth triage means. There are plenty of organizations. In fact, there have even been some podium presentations, or at least one at AAACN, in which an organization presented a quote team approach to telephone triage. That is utilizing RNs, yes, but having them delegate appropriately. And if you don't understand that assessment is the most critical part of the entire triage process, as I said in the webinar, if you get that one wrong, we use the analogy of getting on the wrong train. If you get that one wrong, you're not going to get anything right. So the types of things that have been suggested, I think, in utilizing LPNs is because it seems like, oh, this is only a phone call. We are wasting professional nursing talent by having them collect the data. We could have someone else collect the data and then present it to the RN or present it to a physician and let them make a decision. Um, if you think about that, you'll see the fallacy in it is that we know we interpret, we know we clarify. We know that sometimes we have to say to a patient, what do you mean by that? We also know that on occasion patients self-diagnose. And if you're not extremely alert to that, you're going to wind up possibly going entirely down the wrong rabbit hole.
You're
And
going to be
so,
on their train.
pardon me?
You're going to be on their train that they set
Yeah,
out.
you'll be jumping on their train and nobody will know it. Because if you look at the scope of practice as presented by the boards of nursing, it says that LPNs can do assessment under supervision. That was written for the inpatient setting, where yes, an LPN can go in, if they know how, listen to heart sounds and breath sounds, but that can be validated by the nurse. On the telephone, there is no way to adequately supervise somebody on the phone unless you're on the phone with them, resulting in unnecessary duplication. Bottom line is scope of practice, LPNs are not licensed to do an independent assessment. And I don't think it gets much more independent than being on the phone one-on-one with the patient. And let me just, before somebody tries to work magic here, even if someone is sitting right beside the LPN listening to what the LPN is saying, they're still not supervising because they're not hearing the patient's part. Unless, as I said, you've got a dual headset and you are on the call with them. And what's the sense of that? I hope that answers the question. If anybody has
Yeah.
additional concerns about that, please reach out.
Yeah, no, thank you for that clarification, and thank you again for responding to that question in email, and hopefully that meeting can help. Okay, let's go to the next question here. So we've kind of been talking about quality a little bit already. This specific question, any advice on how to best evaluate clinical quality when the nurse is not asking each and every question in the decision support tool? And that's a kind of a multi-part question, and I have some follow-up on that when the nurse is not asking each and every question. Um, we had some other questions about clinical quality as well. I don't know. I guess I could let me just read the other one as well.
Okay.
And then we
The
can
other one, I think the other one might set this one up well.
so on the subject of AI and QA, do you think it's possible for AI to ever effectively fully determine true quality of calls, specifically clinical quality?
Those are such good
They're such
questions.
Yeah, and they're actually very different. As I was looking at these, I thought that, okay, well, these are both quality questions. Now that I'm reading them out loud, let's go into all areas of quality.
Okay. Um, I I believe that it's understood that if you have a decision support tool in front of you, it may be controversial or subject to debate whether you actually have to ask each question or not. But the one thing that nobody debates is you need to know the answer to all of those questions. So perhaps the patient has already answered it, or perhaps you know from having a conversation with the patient that that question isn't even relevant.
Or the patient's
So,
chart. I mean, if you want
pardon
to
me?
talk about an interesting part of this,
You have
you might
access to
have,
patients.
right, you can't, so you talk about AI or even a human doing QI, they can't just listen. They have to understand what the nurse was also seeing because the nurse might get information from the chart that then that gives them the answer to the question so they don't have to verbally ask the patient.
Well, that's a really good point. We probably confirm a good deal of that information, but we certainly don't have to go back and ask it. Um, I just lost a brilliant thought.
Okay, well, while you're getting the brilliant thought, I'll throw out the easy example. If you're looking at someone's chart and you can see that 5 years ago they had an appendectomy, you're not worried about appendicitis with abdominal pain. And you don't ask those questions, and it doesn't, and a QI that is solely based on the listening to the auditory part of that is going to miss and say, hey, they didn't probe about, right lower quadrant pain. It's like because they looked at the chart, they're not going to have their second appendectomy needed.
And as
Chances
you
are.
mentioned, Carol, you would likely confirm that. It looks like, according to your chart, I can see that you had an appendectomy in 2019. Is that accurate? And then the patient would say yes, which would then lead you to not need to answer all of those questions because you know that answer.
However, I do want to say something here that I think is really critical and gets back to the crux of what the decision support tools are about. If it says right lower quadrant pain, what they mean is they're looking for peritoneal inflammation. What they mean is they're looking for rebound tenderness, which could be related to a lot of things, not just appendicitis. And that's why we have to have a differential diagnosis in our head just to be sure that we're asking questions to drill down to what we know signs and symptoms would be of specific illnesses, but because we're not there to like specifically diagnose appendicitis, we still are going to want to ask about rebound tenderness or, pain with the heel drop or when they cough, because that could still be a meaningful symptom of, you know, I mean, potentially peritonitis from any source. So I think, what you guys are talking about, reviewing the record, very important. Um, I think, though, getting back more to our questions at hand, there is so much, nurses call it their intuition or their gut. And I don't love that because I think what we're doing is making clinical judgments based on information that we're hearing. And we're not always able to say, oh, I know why that bothers me, but it bothers me. And I think we're pulling into our knowledge base, our experience to understand what we just heard isn't
Mm.
right. We may not be able to nail it, but we know that it's not right. I think a lot of what we get that's quote intuitive comes from patients' um, hesitation, their tone of voice, the way that they respond to something like, oh, no, or "Mm, no, I don't think so." Those are very, very different answers and something certainly the nurse would want to follow up on. That I don't think, now, I'm not an AI person, but I don't think AI is going to be able to drill down into, I heard that patient hesitate before she answered her question. Therefore, I need to go back and probe that further.
It is, it's on the edge of that. It potentially will get there. So that you're gonna have smarts. You have AIs um, that are sensing, they listen to customer support calls, moving out of the nurse triage area, but they listen to that. And when they start hearing a caller get defensive or angry, they can identify it and they can escalate it. So they are starting to identify emotions and starting to identify tonality, and that is going to get better. So it will be interesting what comes there. I'll go back to kind of the specifics of the question that you asked, Krista. Can AI do QI? Because we've talked about that within the company
Yeah.
here. And it seems to me that at least at this point, because of some of the things I mentioned too, that the AI doesn't know what else AI doesn't know that the nurse talked to this person a day ago, or that the nurse, there's all sorts of things that the nurse might know that rules out questions. So it's a long time before it's going to be able to be the sole source for QI. But an interesting, because I know a company that has tried to do that, and they're just basically saying, did the nurse read each of these questions? And that is back to the other part of our conversation last week. That's stupid. You don't want your nurses just sitting there blindly reading each question. But AI would be an interesting use if you had all your calls recorded and you ran them all through the AI and you identified which ones might be best for human QI. Because if you're QIing 5% or 2% of your calls or something like that, why not have something select the ones that are most likely to have problems and do your human QI on those and get better results? So that seems to me where at today's stage, AI might be able to be applied in the QI process.
That there's a study for you, Dave. You can get your peeps and you guys do that study and publish it. I'd love to see it. I do think there's one, though, final point to make, and that is that just like with telephone triage, just like with there being ambiguity around what collecting data really is or what telephone triage really is, there's also a lot of ambiguity around what is quality, what represents quality. And it can't, I don't believe it's ever going to be able to be based on the actual patient outcome because we're not with that patient where we can control what is happening to that patient. We have to tell them to get in an ambulance or get in a car if they're going to go somewhere. We have to hope that the people that they go to are knowledgeable about their problem and adequately staffed to deal with it. Um, there are so many elements that are completely outside of our control. I think we've got to do a lot of thinking about what actually represents clinical quality in a telephone triage encounter. And that's something else that we're discussing in AAACN is, did you connect with the patient? That's we know that's a critical piece of the encounter. If you asked all the right questions, read them or not, but you never connected with the patient, then you haven't had a good telephone triage encounter because that trust is missing.
Have to
Um,
establish that rapport with
The,
Pardon?
I'm going to
Yeah.
use that as
yeah,
we talked about before, but that's a plug for next month's.
Kathleen's
Um,
webinar.
yes, we are doing a webinar with Kathleen Martinez, and she really is talking about that connection that you make with the patient. And all the information about how to determine whether something's quality. I'm going to throw that right back your way, Carol, that you get all of your peeps together, and I'm really looking forward to reading that study.
Well, your peeps have patience, mine don't. But
So
I do think I'm sorry.
no, I don't want to interrupt your thought.
Well, I do think that probably we're going to have to truly rethink what quality is. We know that in the face-to-face setting, eye contact, empathy, hand holding, explaining, um, being available to the patient and allowing the patient to be vulnerable. We know that that's nursing. That's part where we
That's
touch their heart. We also have to be able to do that on the phone, or our nursing is not going to be effective. So, yes. So, to answer that question that you asked directly, can we gauge clinical quality when a nurse does not ask every single question? Well, yes, but first we're going to have to define what that clinical quality looks like. And this is one of the reasons I'm going to throw in another issue real quickly. This is another reason that we don't need to be trying to triage people via portal because there is not even synchronous communication. Not only can we not see them, touch them, smell them, or whatever, if we take that telehealth, the telephone or video chat away, we can't even hear them. So all of that goes into, I think, um, a quality encounter.
Yeah. And that's what I was going to summarize was just that question about so you're saying that yes, you can determine quality even if a nurse isn't going through all of those questions. And there was a question in the QA related to not going through each and every, not reading, not asking every question within the Schmidt-Thompson protocols. And Schmidt-Thompson actually in their user's guide, I have it pulled up here. Um, they say that you do not need to ask the triage questions you've already determined the answer to within the assessment. And can be a significant, there should be a significant portion of conversation that happens before, and you talked about this last week, before you are selecting that protocol and going through that checklist. So most likely the nurse should have the answer to a lot of those questions before they actually open the protocol and start going through that triage checklist. And if they're asking them again, that's silly. And also duplicating what they've already done. Yeah.
Yeah,
So,
and possibly interfering with that connection because patient now questions whether the nurse was listening in the first place.
right. So I wanted to segue that question into the other question about not asking all of those questions word for word um, in the protocols.
And
Okay.
since, I mean, not everyone listening to this is a clear triage user, but most nurses listening to this are Schmidt-Thompson users. I'll also throw in the other nuance that not everyone realizes. So as you're going through, you're ruling out questions. The simplistic way of looking at the checklist is you're ruling out questions until you get the first positive. The next thing you layer on there is you're not asking questions that you already have learned the answer to in the assessment. The other nuance that I think sometimes people don't realize, sometimes there might be a block of like 8 or 10 questions. They are arranged in an order, sort of the most common ones up there. Sometimes they have the ones that are most acute. But if all of these questions, for example, say you need to see a healthcare professional in the next 4 hours, they all wind up at that disposition. So the other nuance in there is Schmidt-Thompson in their user's guide said, if you know that the sixth one out of those eight is positive, you don't need to ask the first five because the
Right.
first five are going to wind up at that same disposition. You ask all the questions, you rule out all the questions in the dispositions above, but when you get to a block of questions in a disposition, you should jump to the first positive if you know it, because that's going to get you the quickest outcome to the patient and get the end of the call quickly. So that then the patient can get on to the care that that next person in the chain is going to provide them.
Excellent. You should have been a nurse, Dave.
He missed his.
My next
Well,
life.
I don't think you missed your calling. I think you've done a very nice job at
Well,
what you
that's true.
brought us
Absolutely.
on triage. So, um, okay. All right. Let's switch gears just a little bit, if that's okay. So we also have a question. This was one of the earlier questions in the conversation. Are organizations allowed to modify or customize protocols?
Well, yes, those are your protocols. You can do what you want to with them. In fact, you have a responsibility. Your organization has a responsibility to review them and to be sure that they reflect um, what should be done in your setting, in your community, because we all have different resources. And so, yes, you can and you should. And this is why it may not be an absolute legal requirement to have a medical director, but it is such a good idea to have a medical director because we are going to review those protocols, decision support tools from a nursing perspective and be sure that it represents sound nursing logic. You need somebody with a medical background to also be sure that those questions represent sound medical logic and that they are appropriate for your community. So, yes, yes, you may and you should if you believe it's necessary.
I'll chime in on that. A couple
Yeah.
different thoughts. One comes from Dr. Thompson, who was the first person we interviewed in the speaker series. He has a saying that I've heard him use a number of times: all healthcare is local. So healthcare is provided based on the resources that you have, based on the expectations of your community, based on your patient population. It is local. And the Schmidt-Thompson protocols have 25 years of research and authors' time and feedback from thousands and thousands of nurses and nurse managers to take them to where they are, but your team may do something differently. And so I believe I believe that most, if not all, of the platforms that offer the Schmidt-Thompson protocols allow you to make those customizations. You should have your medical director, or sometimes there's a medical review team or board. Back to your concept, Carol, you may not have been the first person in the world to say this, that two heads are better than one. But having that group there really does it. It can be daunting to do that. I know that as we talk to organizations and say, yes, you have a responsibility to review those, they're like, there is so much here. If you can't do them all at once, a couple different ways to do it. Start with the most common calls you get, or start with your most acute ones, the ones that you worry most about, your chest pain maybe. Review those. Are those being handled the way you want? Start with those. And then at the very least, if you have people questioning how a call is handled, that's an indication to go in and look at the triage questions for that protocol. So don't feel like the whole perfection is the enemy of good. Don't feel like you have to review all of them and it's too much, you're not going to review all of them. Start on it, look at them, customize them. And I will say that two other parts is that the authors, the Schmidt-Thompson authors, so the whole team's there, they specifically legally disclaim responsibility for the outcomes of that. They are not taking on legal responsibility for what happens because this goes back to your whole argument, Carol. It is the nurse. It is the nurse and the nurse's judgment that is ultimately getting the person to the right place. They are not taking responsibility for that, which is even more the reason that if your medical director should look and make sure that your medical director is comfortable with what these protocols are doing. The last piece I will say is that within Clear Triage, we haven't talked specifically about our program, but I will put a piece out of this because I am proud of what we've done here, and we've done it for a reason. We've made the ability for you to customize the protocol something that you can do. You don't have to go to your IT team. So your nursing team, your medical team can make those changes. And then even more importantly, each year when the authors update the protocols, because they are doing research, they are taking on the feedback from around the world and putting those into those protocols, you get the changes from the authors. We merge the authors' changes and the changes you've made, present them to you so you can take a look and say, do my changes match with what they've done? And you can make tweaks and so on. You want a system that doesn't say, well, you've made changes, so now you don't get anything from the authors. Or you don't want a system that every year the authors' changes come and just wipe out your customizations and you have to do them again. So that customization is so important and really is the basis of what we've put together in order to provide a tool for you. That being said, I'm going to throw out another stat just to kind of put in people's head. We've looked at people customizing the protocols. Approximately 10% of our organizations customize the protocols. So that means 90% of our customers, just for round numbers, we have about 1,000 organizations using Clear Triage. So about 100 of them have made changes to the protocols. 900 of them haven't touched them. So that's just, I'll give you a sense of where your organization is at. But best practice certainly is taking a look at them, making sure they match how your team wants your nurses to deliver care.
And I think back, Dave, during the webinar, you asked me how my relationship with Dr. Schmidt has evolved over the years and Dr. Thompson. And that's one thing that I was not aware of early on. The decision support tools that we were using were Schmidt-Thompson clinical content, but I was not aware how dynamically involved they both are in actually doing the research that's necessary and keeping them up to date and current, and then incorporating feedback from clients that they've heard from. And I think that it bears acknowledging that, as Dave said, most, not all, but most of the decision support tools, commercially available decision support tools that I know of, use the Schmidt-Thompson content. There might be different software platforms supporting it, but everybody, a lot of people, recognize the value of those Schmidt-Thompson protocols. And if you feel like something needs to be modified, I just encourage you to get in touch with them, tell them what your concerns are, and it may be that you're onto something that would benefit everyone. It might be a change that Schmidt-Thompson choose to incorporate as well.
Krista, I'm looking at our time and we are spinning through some time here. So I'll let you wrangle us into some sort of sense of order here.
Yep. So we have two questions. Well, if I put two on both hands, that's four. We have two questions left that we have not we haven't answered yet. And just in the interest of time here, we'll see how quickly we can get through these. They're both involved questions, so we'll try to keep it short. But the first question that we haven't answered yet: what assessment gathering tools do you recommend? Over the years, I have found Scholar to really be efficient and get what is needed. Is there something new that you recommend in the current state of nurse triage?
So, two things. I, of course, learned from Sheila Wheeler. I think probably everybody doing triage has either learned from Sheila or somebody who learned from Sheila. And Save, Scholar, and Pamper, and I think she's got maybe a fourth mnemonic now, have long been mainstays of the telephone triage
Could you explain
assessment.
what those are, just
Well,
quickly?
so, mm, okay.
Just briefly, just for the people
Well,
that aren't aware.
they are mnemonics that um, each letter in Saved, Scholar, and Pamper clue you as to an assessment piece or a piece of the history that you need to collect. Once upon a time, I could have quoted it to you. I couldn't now because I don't use it. Which brings me to what I was about to say. I think it's a great idea. It's a fabulous idea, but it somehow or other just never resonated with the way my brain thought. And as a brand new telephone triage nurse with very little education about telephone triage before I went into the practice, I felt a tremendous need to have a system. And so, those of you who have either heard me speak or have our book know that that we also have a system that works for me. I always hasten to say, maybe our system won't work for you, and Sheila's will, or maybe neither will, and you need to make up your own. I think what's a little bit unique about the system that I've advanced is that the last step of it is to take the nurse through a, um, hmm, it- so this phrase may um, confuse people a bit, but to go through a differential diagnosis process. If somebody's complaining of a headache and they say it's a migraine headache, it very likely is a migraine headache, but what are the other things it could be? Did they bump their head? So could this be increased intracranial pressure due to blunt head trauma? Um, do they have meningitis? So could this be a patient who has nuchal rigidity and is febrile? Um, so I think that, it's important, very important to have a system, but you need to be sure that it's one that actually triggers your thinking, supports your thinking instead of interfering with it. And the other thing I would say is the nursing process. I recommend documentation using a SOAPy format, subjective and objective. There's your data collection, your assessment. The assessment is your nursing diagnosis. P, your plan, intervention, evaluation. And if you think your calls through in that fashion, then you, by definition, are following the nursing process.
And just one thing that I might add to Carol. So on with the Schmidt-Thompson protocols, all of the protocols have an initial assessment section, location, severity, onset, that are made available within the protocol. So if a nurse ever needs a quick reference, that it's similar to that kind of Scholar frame of thought, but also specific to the actual symptom that patient might be experiencing. So just for anyone listening, that's always a nice quick reference if you're in a guideline or a protocol that you've got right there at your fingertips.
That brings to mind a client that I had when Krista said, "You've got to be sure that it is consistent with the symptom." I had one client that had a list of questions that were asked no matter what the protocol was. And one of them was onset. Was this onset sudden or gradual? And then, of course, when did it start? The nurse was talking to a patient who had stepped off of a curb wrong and twisted their ankle and might have had an avulsion fracture. And he said, "So did this happen suddenly or gradually?" And you could just, the silence was deafening on the other end of the phone. So be sure that whatever process you're using, it jogs your thinking, it supports your thinking. It doesn't, it's not just a checklist where your only objective is to get a yes or a no out of this patient so that you can move on.
Right. And I
Yeah.
think that echoing what you said, Krista, about the initial assessment questions, because we have people misinterpret the purpose of those as they look at our software. Sometimes people are places, have been places where they are forced to ask every single one of those initial assessment questions. And while those initial assessment questions, as you mentioned, are tailored to the symptom, they still are a general idea. And they're meant to prompt the nurse, give the nurse thoughts about what they might want to explore in the initial assessment. But I'm going to go back to the theme of the conversation with Carol. It is the nurse's judgment, it's the nurse's critical thinking to know what they want to explore during that. The initial assessment questions are just ideas.
100%. Okay. All right. I'm going to move us forward now to our very last question for you today. Um, Probably not a super easy question. So, but how can nurses effectively balance professional nursing practice with common call center expectations?
Whoa. So that is, for those of you old enough to remember, that is the $64,000 question. We're hoping, and as the practice is evolving and growing, and we are getting more clarity about what telephone triage actually is, what it's intended to do, what it can do, I think that we are finding a lot of, quote, common call center expectations that are not necessarily consistent with professional nursing. The organizations that put, I would say, undue emphasis on call length. Um, how long does it take to take care of a patient in the emergency department, you guys? Well, how many things does that depend on? For sure, too numerous to count. Um, so there is no such thing as an average call length. You will have an average call length within your own organization, but that's going to be based on your unique, whatever software you're using, what your staffing levels are, what your patient population looks like. We know that pediatric calls can generally be very quick. We know that did I say pediatric?
Yeah.
Okay. We know that geriatric calls are probably going to take a minute because our patient thinks more slowly, responds more slowly, and has much more medical history and probably many more um, uh, resource types of issues that we need to consider. So here's what I have to say about that. I think, first of all, every telephone triage nurse needs to be crystal clear what we're doing is we are practicing nursing over the telephone or whatever device you're using. Um, in my experience, and I may have said this in the webinar, this is without a doubt for me the most high risk, sophisticated complex form of nursing that I have ever done. And even if you refer back to intensive care units that have patients with 8 bags hanging and ventilators and ECMO and the whole, the fact of the matter is they can see their patient, they can touch their patient, and having a ventilator even lets them know exactly how their patient's breathing. We don't have that. So we have to be so excellent at assessment, so excellent at problem solving and thinking things through. So if, first of all, you need to recognize that you're practicing professional nursing. And then you need to think about what that means and see if you can figure out a way to articulate that to leadership. If you are in a setting where you believe that they are putting emphasis on, say, productivity measures, which I'm pretty sure is what that question was referring to, versus clinical care. Um, we do have to know what our average call length is because it's necessary to know that in order to be able to staff enough nurses. We also know that some nurses just, I mean, like you can tell I'm a talker. Some people might have been able to answer these questions much more succinctly than I've been able to. We all have our own style. Both the nurse has their style of interviewing, the patient has their style of telling their story. So I think it is critical that we understand, yes, productivity measures are important um, to be sure that your department is adequately resourced, but they don't necessarily, in some settings, jibe with clinical excellence.
Great answer.
And it's your job. So what I didn't say was you've got to believe it. You've got to know it. You've got to believe it in your heart. You've got to figure out how to articulate it to the people who are making the decisions. And then you need to articulate it to the people who are making the decisions. Sometimes the nurse that gets on and off the phone most quickly is not the best nurse. You can read every one of those questions and get on and off the phone pretty darn quickly. If you're going to do a good assessment and be sure that you're aware of community resources, your patient's resources, the nuances of what's going on, it's going to take a minute. So I think it's a lot of we've got to know it, we've got to be committed to it, and as ambulatory care nurses, AAACN used to say, we are all leaders, whether we're in a formal leadership position or not.
What a nice thought to end this on. Thank you.
Indeed. Well, thank you again, Carol, for taking the time, first of all, to do the webinar with us last week, and secondly, to do this follow-up call with us. We're so appreciative of you, not just here at Clear Triage, but in the greater nursing community. So thank you very much for all that you do.
Thank you. Thank you. My pleasure.
All right. Well, thank you, everyone. And I guess, Dave, anything else to add?
Nope. It's always a pleasure talking with you, Carol, and I'm glad we got to share the conversation among the three of us and with whoever is going to listen in on this.
Absolutely.
Me too.
Have a great day, everyone.